Hey folks, today we're going to see about a small video presentation in the Department of Periodontics. Myself, Dr. Santosh, reader from Department of Periodontics, SRM Dental College. So we're going to see about a condition that we frequently encounter here, multiple recession. Multiple recession poses a technical difficulty to the dentist and an aesthetic concern to most of the patient. But technical difficulty here is that harvesting a graft for this much zone is going to be difficult, and surgical process is going to be a tough affair. So avoiding second surgical site is of priority in most of the multiple recession cases, and we're going to do a similar technique which uses a xenograft called mucograft, and to enhance its potential of healing, we're going to mix it with IPRF and use as a graft. So we shall delve into the video right away. The recession here is a multiple RT1 type with no soft tissue loss. Before considering the flap design, the factors which we need to see here is the presence of frenum and the vestibular depth. In this case, it is not very favorable, so we need to do a minor modification in this. So you could see the flap design which is employed here is a modification by Zucchelli De Sanctis envelope flap design, where an oblique papillary incision is given to provide a surgical papilla, and this split is continued with a full and a split thickness flap, and no vertical incisions are given. After this, we can also include one tooth adjacent to the recession sites to make sure that we are able to coronally advance the flap. So the next, we are employing an IPRF. The IPRF is obtained by using a low spin concept which uses 70 G force with around 700 RPM speed for 3 minutes. So this IPRF is a liquid PRF with its more platelet and cellular content. The presence of non-polymerized fibrin, which is just going to get polymerized, along with the presence of collagen, and it forms a entangled meshwork with this CMX, the collagen matrix xenograft. The collagen matrix xenograft is a valid alternative. You can see the fibrin clot forming in, and once the polymerization happened, this whole matrix is entangled in the fibrin mesh. The collagen matrix xenograft is a valid alternative to connective tissue graft, stated by a lot of other studies. So adding a platelet concentrate to it enhances its predictable outcome and prevents any other complications seen during multiple recessions. This CMX has two layers, a spongious portion and a compact layer. The spongious portion provides cellular ingrowth so that better tissue stability is obtained. Finally, we are stabilizing the wound with 6-0 sutures. The technique used here is a sling technique, where the flap is coronally advanced and held in position. There was a minor correction that was done here. Being the frenum little high, we had to finish the surgery with a frenotomy to relieve the flap tension. As per the past principle, primary closure and stability is important. The flap tension should be relieved by placing a frenotomy incision.